Hello, welcome back to this clinical educations channel. I'm Boon Singh. Today I'll be talking about cardiovascular and respiratory examinations, specifically catered for the undergraduate internal medicine rotations. So there are three learning objectives in this mini lecture. Number one is to understand the sequential steps in performing cardiovascular and respiratory examinations. They describe the common clinical signs in cardiovascular and respiratory system, and they list the differential diagnosis for common signs in cardiovascular and respiratory examinations. We will first focus on the cardiovascular examinations, and the purpose of a CV exam is to identify common pathologies which could be grossly subdivided into a valvular heart disease or cardiomyopathy. And the different list of differential diagnosis is as shown. To begin the cardiovascular examination, you would position the patient at 45 degrees on an examination couch. The exposure should include the thorax region. At one glance, you should screen for syndromic phases. For Marfan syndrome, which would hint at aortic regurgitations, Down syndrome is linked with ventricular septal defect. Patients with myotonic dystrophies would be linked with mitral valve prolapse. Check for cyanosis, which could point towards congenital heart disease or right to left shunt. Decide whether the patient is at respiratory distress, which could hint at underlying heart failure. The clicking sound of metallic valve replacement could be heard with a naked ear without a stethoscope. Check for midline thoracotomy scar, which could be suggesting of previous bypass surgery or valve replacement. Check for lateral thoracotomy scar, which could be from a previous minimally invasive cardiothoracic surgery or a Blalock-Tausching shunt. You should examine the upper chest for generator box, which would be from the implantable cardiac defibrillator or cardiac resynchronization therapy. Check for bruises of overvarfarinizations. So the conventional rituals of any systemic examinations would start from a peripheral examinations. With regards to a cardiovascular exam, you should look at the hand for oscillar node, Janeway lesions, splinter hemorrhage, clubbings, or peripheral cyanosis. In the forearm, feel for a radial delay or absent pulse or a collapsing pulse. On the face, look for jaundice, conjunctiva pallor, high arch palates, oral hygiene, and a central cyanosis. On the neck, look for jugular venous pressure, which will be raised in heart failure, and feel for the characteristic pulse for its character, volume, and rhythms. You will end with a leg examinations to check for pedal edema and look for saphenous vein harvest scar from a previous bypass surgery. So after you have performed a peripheral examinations, you will move towards the precordium. You begin with inspections for visible pulsations or any scars if you hasn't noticed yet from your screening glance. Next, with palpations, you will locate the cardiac apex with your left hand. Please note the character of the apex, and you should look for a palpable heart sound. Auscultations will give you a lot of information. You will start from a mitral area, first with a bell, next with a diaphragm. What you're looking at is really the murmur of mitral stenosis, which is a mid-diastolic murmur with opening snap, and a murmur of a mitral regurgitations, which sounds as a pensistoid murmur. Next, at tricuspid area, you would listen with a diaphragm. Here, you will look for a tricuspid regurgitation and a ventricular septal defect, which both can sound with a pensistoid murmur and murmur of aortic regurgitations. This area would be an early diastolic murmur. At pulmonary area, you will again listen with diaphragm, and here you are looking for a murmur of pulmonary stenosis and atrial septal defect. Both will sound with an ejection systolic murmur, and you should note that presence of a loud P2. At aortic area, you will again listen to a diaphragm, and here you are looking at the ejection systolic murmur of aortic stenosis. Lastly, listen to the carotid with diaphragm, and you're looking for carotid bruit and radiation of aortic stenosis. At the back, you should percuss for stony dullness, for pleural effusions from heart failure, and note the bivasal crepitations of pulmonary edema in heart failure. The cardiovascular examination should be concluded by performing a urine dipstick, look for microscopic hematuria, check for temperature chart, looking at fever for patients with infective endocarditis, and fundoscopy to look for raw spot. You should present the patients starting with a diagnosis and supporting evidence, and plus the complications in a cardiovascular exam, which is atrial fibrillations, infective endocarditis, ovovafarinizations, pulmonary hypertension, and heart failure. You should mention whether these complications are present or not. So here comes the differential diagnosis of a cardiovascular examination. If you hear a systolic murmur, it could be mitral regurgitations, tricuspid regurgitations, aortic stenosis, ventricular septal defect, and pulmonary stenosis in the order of its prevalence. For diastolic murmur, it could be typically due to mitral stenosis, aortic regurgitations, and pulmonary regurgitations. Next, we would move on to the respiratory examinations. The purpose of this exam is to identify common pathologies which could broadly divided into airway disease, pleural disease, and a stigmata of previous surgery. I'll give a pause for you to look at details of each etiologist. So the respiratory exam should start by positioning the patient's 45-degree on an examination couch. The exposure should be the thorax region, and you should start by inspections. Note the patient's having a dry or chesty or wheezy cough, whether the patient is in respiratory distress, and quickly look for scar of lobectomy, chest tube, and video-assisted thoracoscopy. And look at the chest wall movement, whether there's asymmetry. Look for a sputum port, inhaler, peak flow meter, oxygen cylinder at patient's bedside. And note the patient's overall nutritional status, whether the patient is obese or cachectic. The peripheral examinations specifically for the respiratory system should start by looking at the hand for clubbing, peripheral cyanosis, yellow nail, whether there's a tar stain, whether there's palmar erythema, fine tremor or coarse tremor, or what we know as a flapping tremor. On a radial pulse, you should look for a bounding pulse of a CO2 retention. On the face, look for conjunctiva pallor, central cyanosis, or whether there is a sinus tenderness. On the neck, look for elevated jugular venous pressure and feel for cervical limb adenopathy. On the leg, look for bilateral pedal edema. Next, we will focus on the chest examinations. We will do so anteriorly first before proceed posteriorly. On inspections, you should look for asymmetry of chest wall movement, whether there's dilated chest wing from superior vena cava obstructions. Look for tracheal tube in chronic obstructive pulmonary disease and patients, whether the patient is wheezing. You should palpate for cardiac apex, which would be shifted if the patient is having a mediastinal shift, and palpable P2, which hint at pulmonary hypertension. You should check for chest extension to confirm your observations of asymmetry chest wall movement, and you should locate the tracheal to feel for tracheal deviations. On percussions, you should compare left and right thorax and upper and lower thorax region. The findings could be hyperresonant in pneumothorax, resonant in the normal exam, dull or stony dullness in effusions or consolidations. On auscultations, there are two findings that you should note of. Number one, the abnormalities of breath sound. It could be normal vesicular breath sound or abnormal bronchial breath sound. You should note whether there's added sound of crepitations, bronchi, pleural rub, and egophony. So in a respiratory exam, you would conclude by looking at the temperature chart, check the oxygen saturations, perform a bedside peak flow meter, and a full lung function test. For the presentations of a respiratory exam, you would state the site of abnormalities, whether it is anterior or posterior, left or right, then a diagnosis with supporting evidence, followed by complications such as pulmonary hypertension, atrial fibrillations, and if possible, state the causes. So here are the common diagnoses with their classical findings. For lung collapse, there will be a tracheal deviations towards the ipsilateral side with reduced chest expansions, down percussions, reduced breath sound and vocal resonance. For mass or consolidations of a lung, there will be a reduced chest expansions, downers on percussions, reduced breath sound, and there's added crepitations and increased vocal resonance. For pleural effusions, there will be a tracheal deviations towards a contralateral side. If the effusion is quite massive, there will be a reduced chest expansion and the stony downers, reduced breath sound and vocal resonance on the side of pleural effusions. For pneumothorax, the tracheal deviation will be towards the contralateral thorax if there's a huge pneumothorax. And you should note for reduced chest expansions, hyperresonance, reduced breath sound and vocal resonance at the site of the pneumothorax. So here are the differential diagnoses for lung collapse. It can be caused by a bronchial mass, aspirations, and mucus plug. For mass or consolidations, it could be due to mitotic lesions, pneumonia, pulmonary edema, and pulmonary hemorrhage. For effusions, it could be malignant or non-malignant. For pneumothorax, it could be traumatic or non-traumatic, primary or secondary with the underlying lungs pathology, commonly lung delays from a chronic obstructive pulmonary disease. It is the end of the mini lecture on the cardiovascular and respiratory examinations. We have covered the sequential steps, the important clinical signs, and differential diagnosis in respiratory and cardiovascular examinations, and the points to present in exam. If you have question and answer, please leave in a comment, and we shall see each other again in the next lecture. Bye bye.